Hello everyone, I'm going to present my journal club today. My name is Wasim Ahmed. I'm a nephrology fellow, first year nephrology fellow in East Carolina University. So the article that I'll be presenting today it's about the cold ischemic time and its effect on delayed graft function and overall our renal transplant outcome. It was presented by Dr. Kaler. It was recently published in American Journal of Transplantation in September 2011. So before we talk about CIT-induced DGF and overall graft survival, let's talk about a little bit about the renal transplantation, the one-year transplant, the long-term graft survival, and all that stuff. So this is a Kaplan-Meier curve showing 1 year graft survival from 1988 to 1996. The study was done by Hariharan. It was published in New England Journal of Medicine in 2000. And what this graph is showing is that, for 1 year survival of living related donors, the graft survival has gone up from 89% to 94% from 1988 to 1996. And looking at the disease donor, our graft survival has gone up from 76% to 88% from 1988 to 1996. Moving forward from 1996, the SRTR data shows that from 1998 to 2007, the living donor graft survival, which is again for 1 year, has gone up from around 95% to around 97% or 96, more around 96%, whereas the diseased donor 1 year graft survival has gone up from around 89% to around 91%. So this data is representing the long-term graphs, the 1 year graft survival for extended period of time. But what about long-term graft survival, more than 1 year? Recently there has been a study done that showed the graft survival, long-term graft survival from 1984 to 2002, and we can say that with all the advancement of renal transplantations, with new medications, with more education, with more education, and with more knowledge about renal transplants, our long-term kidney allograft functions have improved from around 45% in 1984 to around 90% in 2002. So there are a lot of factors that are present that can predict long-term survival that needs to be sorted out, talked about, and more learned about. So when we talk about the risk factors for long-term graft survival, we can always divide them into a short-term survival factors and long-term survival factors. For short-term survival factors, we have delayed allograft function or delayed graft functions. We have HLA autoantibodies mismatch, type of the kidney that has been transplanted, SCDs versus ECDs versus DCD kidneys, donor illnesses. Obviously, the more ill a recipient is, the likelihood of graft survival is less. The comorbidities include the diabetes, hypertension, obesity, dyslipidemia, all affect graft survivals in long run. And obviously the centered effect. For long-term survival, we can divide it into certain alloantigen dependent factors, which include the episodes of acute rejections. Obviously, if there is an episode of acute rejection, your long-term graft survival goes down. The HLA mismatching and sensitization is also a known risk factors for poor graft survival. For allo antigen independent factors, obviously if you have got tissue injuries in the form of repeated infections, prolonged cold ischemic time, if you've got inadequate renal masses, if you've got drug incompliance, if you've got comorbidities like hypertension, dyslipidemia, obesity, and obviously recurrent or de novo glomerulonephritis, especially the FSGS, the membranous, the type of the kidney donors also include in this category. So coming to our article that I'll be talking to you in few moments, the influence of cold ischemic time on delayed graft function and on kidney transplant outcomes. Let's talk about cold storage first. So the history of cold storage dates back to 1849, and this data is all taken from International Society of Organ Preservation. So in 1849, Lobel was the first person who attempted perfusion of an isolated organ. In 1937, Lindbergh created the first perfusion apparatus. In 1953, Dr. Lepchinsky was the first person who transplanted the rims and the kidneys preserved at 4 degrees centigrade. In 1969, Collins developed the first Euro-Collins cold storage solution. 1987, Belzer developed the UW solution, or University of Wisconsin solution. So what is cold ischemic time? When we do a procurement of an organ, we flush the organ with a cold preservative solution, and then we cool it to 4 degrees Celsius to minimize the ischemic injuries and to increase the viability. Now, why this is done? We do it to reduce the degradative reactions and to slow it down. But having said that, the important thing is we cannot halt it. We cannot completely stop it. What cold preservation do is that it slows the metabolism by a factor of 11 to 12. When we look at the components of cold ischemic time injury, the components of CIT is both ischemia and hypothermia, coupled with reperfusion and remorming injury, which happens during or after transplantation. And what does that mean? So when we preserve an organ with cold storage, what we do is we convert the aerobic metabolism to anaerobic metabolism, and what it does, it causes accumulation of lactic acid because of anaerobic metabolism of glucose. What it also do is it changes your osmoregulation, so there is a reduction of interstitial oncotic pressure due to interstitial expansion and edema. There is a cell swelling due to reduced sodium potassium ATPase activity and reduced ATP levels. And what it do microscopically is that if you compare a normal cell at 37 degrees Celsius doing an aerobic metabolism, doing fine, and when you compare it with these cells which have been under cold ischemia, or who are preserved with a cold solution at 4 hours at 4 degrees Celsius, you can see the mitochondria begins to swell down. The swelling gets progressively bigger in 12 hours, progressively more bigger in 24 hours, and finally there is total disruption of membrane. You can see there is no membrane here, you cannot see any mitochondria, so there is a total disarray here. And if you look at the same cell under DFO solution, you can see more iron staining, which is also a hallmark for cold ischemic injury. So the new pathophysiology for cold ischemia includes a combination of apoptosis, increase in your calcium inside the cells, your production of free radicals, your release of free ions, and then F2 isoprostinases that also causes cold ischemic injury. Now Ojo in 1997 did a very interesting study. He looked at delayed graft function and found out the risk factors and implication on renal allograft survival, long-term renal allograft survival. So he used USRDS data from 1985 to 1992. Total number of patients were around 44,703, and they found out the risk factors for DGF obtained through a logistic regression model. And what he found out that as your cold ischemic time gets prolonged, your odds ratio to develop DGF goes up. And he also found out that the donors, if the donor age is more than 50 years, the likelihood of getting or developing a delayed graft function is higher, and if the recipient is African American, you've got more chances of delayed graft function. And if we specifically look at his data from cold ischemic time, what he proposed that the adjusted odd ratios or adjusted odds of getting or developing a delayed graft function was higher by 23% for every 6 hours increase in cold ischemic time. He also stated that the risk of delayed graft function increased by more than twofold when your cold ischemia time exceeded 24 hours, and substantially higher with cold ischemic time of more than 36 hours. So what he was trying to say is that the more your CIT or your cold ischemic time is, the higher the chances to develop a delayed graft function. And he also presented his data on the overall graft survival, and as compared to graft survival in 60 months post transplantation when you don't have any delayed graft function, no acute rejection, and if you compare it with acute rejection, delayed graft functions, and a combination of acute rejection and delayed graft function, your graft survival goes down. So to summarize, what Ojo presented was that the Ojo analyzed 44,703 patients through the US RDS data from 1985 to 1992. Cold ischemic time was found out to be a single most important factor for delayed graft function, and delayed graft function was found to be an independent risk for long and short-term graft survival. There was another study done by Shoskis. It was presented in Journal of Transplantation in December 1998. What he tried to figure out was the effect of cold ischemic time on incidence of delayed graft function and acute rejections before transplant, and he used the UNOS data from 1994 to 1997, and what he found out that as the cold ischemic times increases, the risk of delayed graft function goes up. So the fraction patient getting delayed graft function goes higher, and the risk of getting rejection goes up as well, as compared from here in 0 to 24 hours compared to 49 to 90 hours, your risk of acute rejections also go up. So there's been a linear correlation. What shows presented was that he looked at 27,000 patients from UNOS from 1994 to 97. He found out that delayed graft function was confirmed to correlate with cold ischemic time, and he also presented and he also proposed that the prolonged cold ischemic time related directly to acute rejection. So the question here arises, to what extent cold ischemic time has influence on graft survival if considered independently? And if there is an extent, then what degree of CIT or cold ischemic time results in a poor graft survival? And up till now we don't know this. The answer to this question. Why this question is important? The question is important because recently Shapiro in 2010 presented that around 23% of the kidneys of 23% of the DCD kidneys gets discarded. 44% of the ECDs kidney that get discarded, and around 19% of all the kidneys donated for transplantation in US gets discarded. And the data is really shameful, because now we know that the CKD prevalence is going up and up. The prevalence is as high as around 20 to 25% in US population. We know that there is a long waiting list. There is a waiting list of 3 to 5 years for patients to get renal transplant. We also know that people die when they are on a waiting list for transplant. We know that their outcome without the renal transplant while they are on hemodialysis is bad. We know that their outcome while they're having a progressive chronic kidney disease is bad. Yet we are discarding around 19% of the kidneys that should have been transplanted. And why there is such a high rate for discard? The proposals or the hypothesis is that it is getting difficult to find out accepting centers outside the local donor services area, which causes significant delay in transference. Because there is a significant delay in transference, there is a significant increase in cold ischemic time. When there is a high cold ischemic times, then the doctors, the surgeons don't want this kidney to be transplanted, because they think that with a higher CIT, the overall chances of DGF and overall chances of graft survival would be less. And as previously discussed, we already know that early injury with cold ischemia can cause chronic yet progressive yet indolent injury to the kidney that can lead to long-term graft survival. We also know that what we have discussed right now in earlier sections is that the CIT has been clearly shown as an independent risk factor for DGF, and DGF is generally associated with inferior graft survival. But what we don't know right now is the direct impact of cold ischemic time induced delayed graft function on overall graft survival. And this is where I'm going to present this study. and hopefully we can clear a few things up. So the objective of this study was to determine the risk associated with transplantation of diseased donor kidneys with long cold ischemic time. The data was obtained through SRTR between 2000 to 2009. The data analyzed included patients and graft survivors of adult transplant recipients of diseased donor kidney pairs, and this is important that the data analyzed included donor kidney pairs. They were not talking about individual kidney transplants. They were talking about diseased donor kidney pairs with discordance and incidence of DGF. That means that if you've got two kidneys from a diseased donor, one kidney developed DGF, another kidney does not develop DGF. So one kidney there is a DGF, another kidney there is no delayed graft function, and they're comparing the data on those two particular kidneys. So they are comparing the paired kidneys. What they also tried to do was to find out the association of induced ischemia or cold ischemic time with incidence of delayed graft function and acute rejection using the same paired donor approach. So the study design, through the SRTR data, they found out that 54,565 paired kidney donors were identified. Out of those 54,565 paired kidneys, 15,833 paired donor kidneys were excluded from the study because the made kidney did not get transplanted. 27,340 paired kidney donors were excluded because either both or neither developed delayed graft function, and 23,110 paired kidney donors were excluded from the study because either they had same cold ischemic time or they have unknown cold ischemic time. So out of 54,565, there were 9,082 paired donors that were evaluated. So analysis was done through a Cox regression model, which was used to compute covariate adjusted patient survival, graft survival, and death-centered graft survival hazard ratios. And the following thing is very important. The recipient variables that were included, that were confronted, and that were covariately adjust include lot of factors: age, gender, race, BMIs, cause of ESRD, retransplantation, time on dialysis pre or post placements on less than before transplantation, number of HLA mismatches, your PRA levels, education of the recipients, their insurances, and whether they were machine perfused or not. So all these variables were identified. They were confronted. Paired donors were categorized using a donor identifier available in the registry. Recipient outcomes were compared between paired donors and stratified by CIT group, or the cold ischemic time group. So they made two groups, one group with a shorter CIT and the second group with a longer CIT group. Few definitions before we proceed ahead. ECDs mean donation from donors either if they are more than 60 years of age or if they are more than 50 years of age with two of the following: either their serum creatinine is more than 1.5, they've got high blood pressure, or they have got death from CVAs. SCDs, all other donations not fitting ECDs criteria. DCD is donor from cardiac death, and DGF or delayed graft function, meaning need of hemodialysis within 1 week post transplant. If you look at the recipient characteristics by CIT group, the recipient characteristics on both the groups are very identical. The only two differences here in the two groups include the CIT, which obviously the patients have been subdivided into CIT groups, so it has to be there, and the non-local donor. Obviously, if you've got a non-local donor, your CIT time will go up because the time required to ship that particular kidney to a non-local donor center would be high, and therefore you've got a longer CIT. Other than that, the recipient characteristics were very similar in both the groups. So when they look at the delayed graft function by cold ischemic time group, what they found out is that when they compared the cold ischemic time from a shorter CIT group, that is 15 hours or less. So if we, and the data what they presented is, if we go more from 15 hours, so 15 plus 1, 15 plus 5, 15 plus 10, 15 plus 15 hours, the adjusted odd ratios to develop a DGF or delayed graft function goes up. So from 1.81 to adjusted odds ratio of around 4.4. So what they found out that your overall delayed graft function for a longer CIT group was around 57%. The overall incidence of DGF in a shorter CIT group was around 43%, but when they subdivided the longer CIT group for 5 hours plus shorter CIT group, there is a rise in incidence of delayed graft function of around 2.5-fold, 3.3-folds in more than 10-hour group, and around 4.4-fold in people with more than 15 hours CIT difference. But when it comes to graft survival and cold ischemic time, it was very interesting to note that the graft survival was not different, even with CIT with more than 5 hours different from short CIT group and 10-hour difference from a short CIT group. You can see that the graft survival was same in both the groups. The only place where there was a difference in graft survival was when the CIT was more than 15-hour difference from the shorter CIT group, where the difference goes up to around 27%. But if you look at the overall graft survival, there was no difference. And when we look at the graft losses and deaths with CIT group, we can say that in all the groups for short or long CIT group, there was the adjusted, I want you guys to look at the adjusted hazard ratio. The adjusted hazard ratio was not statistically different in any of these groups. So the chances of having a graft loss was not different in short and long, even in subgroups of long CIT groups. If you look at the death-centered graft loss, the adjusted hazard ratio was the same. So there was no statistical difference between the two groups. The only place where there was a difference was on patient death. More patient died in longer, that is more than 15 hours CIT group as compared to short CIT group. If we look at the acute rejections in 1 year and its relationship to cold ischemic time, we can find out that 1 year of the incidence of acute rejection in 1 year is around 11% in both the long and short CIT groups. And as we go up, as we subdivide the long CIT group, there is no statistical difference between the short and long group. If we look at the delayed graft function and graft survival for CIT paired donors by disease donor category, so you have got different disease donor categories: your SCDs slash non-DCDs, your ECDs slash non-DCDs, your SCDs slash DCDs, and your ECDs slash DCDs disease donor category. If you look at the adjusted hazard ratio, there is no statistical difference. So even with using different disease donor category, there is no difference in your overall graft loss with CIT or cold ischemic time. So it doesn't matter. The only data that we don't have is for ECD slash DCD group, where the number was insufficient for a correlation. So to summarize, for 9,082 paired donors that were analyzed through SRTR data from 2000 to 2009, the adjusted odd ratio for developing a delayed graft function was significantly higher with CIT when CIT was longer than 1 hour, 5 hours, 10 hours, and 15 hours compared to shorter CIT transplants. But when multivariable model adjusted to different co-found with different variables, the overall graft survival with and without DGF was similar. There is it also the article also suggested the results also suggested that the delayed graft function is specifically induced by cold ischemic time has limited bearing on long-term outcomes. And why is this study so important? We know that the previous large studies, the ones that I proposed when that I talked to you guys earlier on, and also the other big studies like the collaborative transplant study and the analysis of US RDS data found poor outcomes with a prolonged cold ischemic time of more than 18 hours and more than 6 hours respectively. But I think the major limitations of those studies is that they were unable to achieve multivariate models to accurately adjust for important donor quality confounders, and this problem was solved by using the paired kidney analysis in this study. I think this study is a landmark showing that increased cold ischemic time does not impact long-term survival of the kidney grafts. And again, why is this important? We are losing valuable kidneys that should have been transplanted to our precious patients. We are losing a lot of kidneys that we should not be losing. We should be more proactive in transplanting these kidneys because we think that the CIT is a major risk factor for decreased graft outcomes. And I totally agree with the editorial that was published after this, after the study that I've discussed with you guys were published. The editorial was responded by was written by Dr. Terasaki in response to the article of Dr. Kyler that I just presented, and I definitely agree with him that it's time to rethink the risk for kidneys. He shared a very unique experience in his editorial. What he said was that, and what he knew was that 27 kidneys which were just unusable by US centers because of donor being AB type was sent to Japan. First group of 13 kidneys sent in 1983 had an average cold ischemic time of 42 hours. The second group had a cold ischemic time of 65 hours with average age of donors of 52. What he said was that 1 out of 27 kidneys has had acute tubular necrosis, but here's the deal. The overall survival was 72% in 10 years. And with that extreme experience, I thank you for listening and allow you to think about this dilemma in more detail. Thank you.